So these are very important for practicals also. Hepatic encephalopathy, most commonly asked questions. So we look into first definition. So what's the definition of hepatic encephalopathy? It's a neurological and neuropsychiatric abnormality caused by accumulation of neurotoxic substances. It's not just ammonia. So neurotoxic substances in the bloodstream of patients with liver dysfunction. So what is the mortality rate? It exceeds 50% in the first year. So with liver transplant, it improves survival. So if you do a transplant, the survival is more than 70% in these patients. So what are the potential triggers or precipitating causes? So most common will be infections, can be a GI bleed, constipation, dehydration. Mainly the patient will be on diuretics for the ascites and all that. So diarrhea, vomiting, fluid restriction, excessive paracentesis, not replaced with adequate albumin, electrolyte imbalances like hypokalemia, hyponatremia, alcohol use disorder, benzodiazepines. This is something that can potentiate hepatic encephalopathy and kidney dysfunction, uremia. So these are the triggers of hepatic encephalopathy. So how can you classify? Based on the etiology, it is classified into A, B, and C. A being acute liver failure, B any portosystemic shunt. Okay, without any, some patients can have congenital portosystemic shunts also without any pre-existing liver disease. So that is type B. Type C is cirrhosis or chronic liver disease related. So this is the type of acute hepatic encephalopathy. And the vast heaven grading, they have graded from 0 to, that is minimal, to grade 4. So grade 0 or minimal and grade 1 is considered as covert, whereas grade 2 to grade 4 is overt. Okay, so based on the clinical symptoms, it is classified as minimal if only there is abnormal psychometric test. Grade 1, there is attention deficit, altered sleep pattern, some personality changes, subtle changes. Okay. Grade 2 will be lethargy, apathy, disorientation, personality changes. Grade 3, patient is somnolent, semi-stupor status, responsive to stimuli, grossly disoriented, confused, and bizarre behavior. Grade 4 is patient is in coma or like in stupor. Okay, this is the vast heaven grading. Based on the episodes, okay, episodic is bouts occurring more than 6 months apart, a period of bout and then it subsides, and 6 months later another episode occurs. So that is episodic. Recurrent, the time between the hepatic encephalopathy episodes is less than 6 months. Persistent, when there is persistent behavioral changes that is superimposed on exacerbations. So these are the various types of hepatic encephalopathy. So this is a very complicated slide, but I'll make it simple. So what's the pathophysiology? So when we look into what happens here is in the intestine. We'll come to the intestine. Here there is ammonia production. The colonic bacteria help in producing this ammonia. So this ammonia is kind of metabolized in the liver, brain, muscles. So liver and the periportal hepatocytes, it's converted into urea, whereas in the perivenous hepatocytes, it's converted into glutamine. Even in the muscle, ammonia is converted into glutamine by the glutamine synthase enzyme. Okay, this is a very important enzyme. So what happens in the brain? In the brain, it goes into the astrocyte and glutamate synthase converts ammonia into glutamate and lactate. So this is the normal metabolism. So also kidneys play a role in metabolism. So these are the various organs that play a role in ammonia metabolism. So what happens in cirrhosis? In cirrhosis, there is liver failure, hepatocyte dysfunction, there is portosystemic shunting, there is sarcopenia. So the muscle mass is getting lost. There is electrolyte imbalance, which are potential triggers. There can be precipitating events like GI bleed, infection, and all that. And all these conditions trigger a state of systemic inflammation. Okay, this systemic inflammation is the first thing that you need to remember. So this causes an oxidative stress and increase in the blood-brain barrier permeability, along with ammonia not being adequately metabolized by the liver. So there is inflammation, blood-brain barrier permeability that is kind of worsened, and hyperammonemia. So because of this, the ammonia as well as other free radicals enter into the brain. So ammonia gets into in the astrocyte, it is converted into glutamine. So and also due to cytokines, reactive oxygen species, nitrogen species, lactates, and other neurosteroids, there is astrocyte swelling, which results in cytotoxic brain edema and raise in ICP. And this is the primary pathophysiology of hepatic encephalopathy. Okay, the next theory what is put forth is the GABAergic theory, which means it is not just ammonia, but also there is a modification in the protein. There is some protein modification and the gap junctions, okay, in the brain cells, which is getting modified, as well as microglial activation, and the GABAergic tone is also modified, and NMDA stimulation occurs. Okay, there is excessive stimulation, that is kind of toxicity which occurs, which results in death of the brain cells. So this is one of the other mechanisms by which senescence and death happens in the brain cells. Okay. So the other thing is the branch chain amino acids are there should be a balance between the branch chain amino acids and the aromatic amino acids. In cirrhosis, the branch chain amino acids come down and the aromatic amino acids increase. So these aromatic amino acids like tyramine, serotonin, and octopamine, so these act as false neurotransmitters in the brain, which cause again excitotoxicity and then senescence and cell death. Okay, so these are the various factors that contribute to hepatic encephalopathy. So it is not just ammonia, but a lot of factors, especially inflammation, free radicals, okay, and there is a GABAergic tone that is modified and NMDA stimulation. So these are the various factors that play a role in hepatic encephalopathy. And ammonia levels actually more than 100 or 150 are supposed to be very high, and it can result in significant increase in the ICP and brain herniation. Okay. So is there any role of measuring ammonia in this patients? Okay, ammonia has a good negative predictive value. If it is normal, it has a high negative predictive value. If it's more than 120, there is a high risk of ICP, high risk ICP and brain edema. It can result in herniation also. It has a good prognostic value. Okay, if there is no reduction in ammonia with after you initiate the anti-encephalopathy measures, it is not coming down, it has a prognostic value. Okay, so the patient's prognosis is as such going to be poor. But does it follow the severity? Okay, serial measurements, does it have a role? Okay, no, there is no role of kind of serially monitoring the ammonia levels to look in for the severity of encephalopathy. Okay, and advanced degrees of in advanced degrees of hepatic encephalopathy, you need to understand. So we spoke about other factors in addition to ammonia. So those factors are also important. So it is not just ammonia, other factors also play a role. So measuring ammonia is also need to be done appropriately. For example, if there is a time delay between the sampling and measurement, so that will have an impact of ammonia measurement. So tourniquet which is tied, fist clenching, so all those things, and sample processing, so all those things can give you a falsely elevated ammonia levels. So you need to be very careful when you're doing the sampling as well. Okay, ammonia cutoff, that is like the prognostic value, a cutoff of more than 80 is associated with a high risk of death. Okay, it is considered as one of the biomarkers. So how do you approach a patient with hepatic encephalopathy? First, look into any patient with liver failure has some neurological signs. Looking for focal deficits. It could be a bleed also. So patient is coagulopathic. If the patient has seizures, focal neurological deficit, get a brain imaging to rule out a bleed. Okay. Then make sure all of the precipitating factors are being addressed, like electrolyte abnormalities, GI bleed, infections, and any new benzodiazepines or sedatives that has been added. Make sure all of those are kind of discontinued. Okay. And the CT can also show cerebral edema. Okay. If you're doing an MRI, okay, and normally we don't do MRI in an unstable patient, but then MRI findings would be hyperintensities and globus pallidus, that is pointing towards a metabolic encephalopathy. EEG will show triphasic waves, okay, in grade 1 to 2. And beyond 2, in grade 4, it will be slow progressing. So in the as per the Vast Haven grading, up to 3 grades, there will be a triphasic pattern. 1, 2, and 3, there will be triphasic pattern. And grade 4, when the patient is in stupor or in coma, there will be progressive slowing of the rhythm. And also do other diagnostic tests to rule out infections like paracentesis, drug screening. And uh, in patients with chronic liver disease, start lactulose, rifaximin, okay, rifaximin, and looking for if there is a recurrence and if the patient is not improving, looking for any shunts actually. There could be some portosystemic shunts that could be the reason for hyperammonemia. So consider embolization of the shunts as well. Last would be liver transplant. So, and in a CLD patient, so correct the etiology and manage with lactulose rifaximin. In ALF, in a patient with acute liver failure, you try to reduce the ICP. So we have already looked into these things: head up, intubation, then osmotic therapy, mannitol, and neuroprotective measures. So what are the osmotic laxatives do? So lactulose is a laxative. So how does it act? It is a non-adsorbable disaccharide. So it has a negligible impact on the gut microbiota, but it increases the intestinal transit. So what happens is that lactate, it gets converted into lactylol and lactate, and it acidifies the bowel milieu. So because of the acidification, NH3 is converted into ammonium ion, NH4. So this ammonium ion will not be absorbed in the gut. So thereby it decreases the absorption of ammonia, as well as by increasing the intestinal transit, the formation of ammonia will also come down. But what will be the disadvantages? Disadvantages being diarrhea, vomiting can lead to electrolyte imbalances. The dose of lactulose is 15 to 20 ml BD. So you have to titrate it to the amount of stools the patient passes. The target would be to at least 3 times a day. Okay, what is the difference or comparing lactulose with polyethylene glycol? So in an RCT, it has been found that polyethylene glycol improved overall grade of hepatic encephalopathy after 24 hours, but reduced days to hepatic encephalopathy resolution and shorter hospital stay. So the polyethylene glycol is supposed to be more beneficial. So antimicrobial agents like rifaximin. So rifaximin is a semisynthetic non-aminoglycoside which acts on the gut enteric bacteria. So it binds to the DNA-dependent RNA polymerase, inhibiting the bacterial RNA. So it is administered orally for 400 or 550 BD to thrice a day. So minimal absorption. So it acts intraluminally. So the risk of bacterial resistance is low. A combination of lactulose and rifaximin was more effective than lactulose alone in the improvement of hepatic encephalopathy. It reduces the hospital stay, reduces the mortality, and also which was due to sepsis related deaths. Okay. Is there any role of probiotics? Probiotics are live bacteria which are believed to improve the gut dysbiosis and negatively impact the ammonia production. So, is there any role? As per the studies, a little effect on mortality. It has some effects in ammonia lowering. Current recommendation may lead to improvements, but definitely not one of the proven treatment for hepatic encephalopathy. Okay, branch chain amino acid. How does this help? Okay, a Cochrane review suggested that the manifestation of overt hepatic encephalopathy improved, but there's no effect on mortality. So how does this act? Okay, it acts in the brain and muscle. In the brain, it competes with aromatic amino acids. So it prevents the negative effects of the aromatic amino acid, which act as false neurotransmitters. In the muscle, what happens is that it promotes muscle protein synthesis and thereby helps the muscle to metabolize the ammonia. So the alternative mechanism will of ammonia metabolism will improve. So L-ornithine, L-aspartate, LOLA. So how does this improve? So meta-analysis compares LOLA with placebo suggested that it improved overt hepatic encephalopathy. So it stimulates the urea cycle in the liver. So aspartate provides nitrogen for the urea. So it helps in the metabolism as well as in the muscle. It increases glutamine production. So it acts in the muscles as well as in the as well as in the liver, and it has some effect in the kidneys as well. So next option would be, in case if there are photosystemic shunts that are detected, either a contrast CT or a MR abdomen will help in detecting the shunts. So in recurrent episodes wherein, especially when the encephalopathy is disproportionate to the liver dysfunction, we need to think of these photosystemic shunts. Especially patients might have some type B encephalopathy. We saw type A, B, and C, wherein A is acute liver failure, B is due to photosystemic shunts. So in this scenario, we'll have to look in for, in recurrent cases, we need to look in for photosystemic shunts. And if the shunts are very large, we should think of embolizing these shunts. So clinical trial data and many case reports and case series, okay, not large RCTs. So these have shown that embolizing these shunts can elevate the hepatic encephalopathy, particularly in patients with MEL less than 11. Other thing would be volume expansion with saline over 1 hour to reduce ammonia. So this is something that can be done but not beneficial on a long-term basis. Hemofiltration, that is CRRT, can be done to decrease the ammonia levels, but it can reoccur. So albumin and extracorporeal albumin dialysis. How does albumin help? Albumin acts as a plasma volume expander. It has anti-inflammatory properties. It has the ability to bind to many toxic substances like bile acids and many other reactive oxygen species, nitrates, and it can act as a antioxidant also. So lactulose and ammonia more effective than lactulose alone. Okay. So what does the study say? 2 RCTs in patients with cirrhosis showed faster reduction in the severity of hepatic encephalopathy. So, but ultimately no survival benefits. Okay, whatever strategies we have looked into, uh, rifaximin, lactulose, embolization of the shunts have a definitive role. So there has been questions on newer drugs for hepatic encephalopathy. So this is something that we can look into. So polyethylene glycol. So compared to lactulose, it improves hepatic encephalopathy. Flumazenil is a benzodiazepine antagonist. It's known to improve the symptoms, but the effects are transient and it does not affect mortality. So after the effect of flumazenil comes down, the patient will again go into a phase of encephalopathy. Zinc, because cirrhotic patients have long-term zinc deficiencies, zinc supplement has been tried in recurrent encephalopathy, hepatic encephalopathy, but it has not shown any consistent improvement. Sodium benzoate. Okay, this is something that increases the urinary excretion of ammonia by converting into hippurate. Okay, the dose is 5 gram twice daily. So it's comparable to lactulose in one double-blinded control trial. So there is some evidence for sodium benzoate. Closure of large post-systemic shunts that we looked into. L-carnitine. So this has some animal data, not still tried in human. NMDA receptor antagonist. So we looked into one of the mechanisms is NMDA activation. So if, thinking of an antagonist, that is memantine. So it has some role, but still human studies are lacking. Other things, serotonin antagonists, opioid antagonists, probiotics, fecal microbiota transplant. So these are something that are more into futuristic. So newer drugs, other drugs would be sodium phenyl barbiturates. So these are for patients with genetic urea cycle disorders. As per according to the randomized control studies, they have found to lower ammonia levels, reduce hepatic encephalopathy and hospitalizations. Liposome supported peritoneal dialysis. There has been evidence for this liposomes which helped in detoxification. So these bind with the ammonia. So when this peritoneal dialysis is done with the micrometerized liposomes, they bind to ammonia and then they neutralize it, and it helps in removal of the ammonia. So this has some effect in ammonia lowering effect, and then attenuating brain edema compared to conventional peritoneal dialysis. Combination of L-ornithine and phenyl acetate. So it increases the muscle ammonia detoxification by stimulation of enzyme, this glutamine synthase. Okay. So other things would be glutamine synthase replacement. Okay, this enzyme replacement, there has been recombinant glutamine synthase AM553. So this is also being newly studied. So this has a role in conversion of this has a role in the metabolism of ammonia, especially in liver and the muscles. Other is GABA receptor modulating steroid antagonist, the GAMSA. So this one, the AS100 is the molecule that has been studied. So this has increased GABAergic tone potentiated by neurosteroids, with which will contribute to neuroinhibition. So it has a role in mitigating the hepatic encephalopathy. So that is about hepatic encephalopathy and newer drugs. Next, we'll go into another important topic in practical aspect as well. That is chronic liver disease. So chronic liver disease is an acute hepatic insult manifestation in jaundice and bilirubin more than 5 milligrams and coagulopathy, complicated within 4 weeks by clinical ascites or encephalopathy in a patient who is previously diagnosed or undiagnosed with chronic liver disease or cirrhosis. Just to break this definition, so there is a hepatic insult and the patient has a jaundice and bilirubin elevation and coagulopathy, or coagulopathy defined by INR more than 1.5 or a prothrombin activity. So there is an insult, there is a effect in the liver. So within 4 weeks, it is complicated by ascites and encephalopathy. This is where we term as acute on chronic liver failure. Okay. So how does this happen? So any patient who has a baseline cirrhosis, what happens is that any insult results in inflammation in the liver cells, thereby resulting in fibrosis. There is nodular regeneration, which is happening, ultimately resulting in hepatic vasculature being kind of affected due to there is increased resistance in the hepatic blood flow. So as the portal blood resistance to the portal blood flow increases, there is portal hypertension. So when there is a trigger by an infection or by alcohol, what happens is that there is inflammation in the liver as well as systemic inflammation caused by the damage associated molecular proteins or the pathogen associated molecular proteins due to TLR activation. So this results in circulatory dysfunction and multi-organ failure. So this is how the patient, primarily having a liver disease, decompensates and ends into multi-organ failure. So when we look into what are the different phases or a patient can present to us, a normal liver after an acute insult can end up in an acute liver failure, which can recompensate or end up in a liver transplant, or it can finally end up in a fulminant liver failure. Whereas in chronic liver disease, in chronic liver disease and cirrhosis, if there is a acute insult, what happens? A patient might be having, without any fibrosis, a chronic liver disease with the synthetic functions of the liver being affected. So that is CLD. So in this patient, wherein an acute insult happens, the patient might have jaundice, which is progressing to ascites or encephalopathy within 4 weeks. So that is known as acute on chronic liver failure. A compensated cirrhosis, that is, a patient has fibrosis, portal hypertension, then after an acute insult decompensates into GI bleed, encephalopathy, ascites, HRS, or a combination of any of these, And this, after the first insult, either the patient can recompensate or end up in a completely decompensated cirrhosis. A decompensated cirrhosis, again an insult, the patient can finally worsen. How can you actually classify, or how can you stratify these patients? There is two classification. One is the CLIF score, CLIF C organ function score, which is the chronic liver failure consortium organ failure score, and the AARC, that is the Asia Pacific Research Consortium acute and chronic liver failure. So these are the two scoring systems that you need to remember. So the definitions, when we look into, there are various societies which has put forward various definitions, but we need to know at least these three. There is also a Chinese definition, but the East Asian, Asia Pacific, North American Consortium. So these are the three definitions we need to remember when coming to acute on chronic liver failure. So when we consider the European here, they define acute on chronic liver failure as acute worsening of a pre-existing liver failure triggered by an event leading to 4-week increased mortality, the bilirubin concentration being more than 12, and extrahepatic failures. There are 6 organ failures that have been defined. That is creatinine more than 2, needing dial, or any creatinine value wherein the patient is on dialysis, hepatic encephalopathy grade 3 or 4, patient on vasopressors, respiratory with the PF ratio less than 200, and patient on mechanical ventilation. The primary etiology wherein these patients being classified are alcohol related or bacterial infections, and the Europeans have put forth the CLIF SOPA. So this classification is from the European guidelines. The Asia Pacific mentions acute on liver failure as jaundice and hemostat, that is coagulopathy, within 4 weeks, and resulting in ascites and encephalopathy. So here the bilirubin is more than 5, INR is 1.5. So the Asia Pacific is mainly liver-centric. Liver-centric in the sense mainly it considers the liver derangement, the bilirubin more than 5 and INR 1.5 and prothrombin activity as the main factor. The secondary factors, so these are considered as additional factors, whereas European and North American consider the extrahepatic as as the factors of decompensation of acute liver failure itself. So other here, there are four organ systems that are being considered. Primary viral infections are being considered in this acute insult. Okay, the North American, here they have considered the chronic liver disease with or without cirrhosis, and the mortality which has been described is in 3 months if left untreated. Okay, the organ systems being a patient on dialysis, grade 3 or 4 encephalopathy, circulatory dysfunction, patient on mechanical ventilation, primary bacterial infection is the type of insult, and this is within 3 months. Next, going to the classification. So we looked into the grades. So the ACLF, this is the grading system. So this is the Chronic Liver Failure Consortium organ failure score. So based on this, so they have looked into 6 organ dysfunction, and they have allotted a score of 1, 2, and 3. So the bilirubin less than 6, 6 to 12 or more than 12. Coagulopathy 2, 2.5 and more than 2. Creatinine value 2, 2 to 3.5 and 3.5 or renal replacement therapy. And encephalopathy grade 0, 1 to 2 and 3 to 4. Circulation, use of vasopressors with a MAP less than 70, and respiratory PF ratios more than 300, 300 to 200 or less than 200. Okay, or a SpO2 FiO2 ratio. So these are the various organ systems that they have looked into, and based on how much involvement is there. So no ACLF is no organ failure or single non-kidney organ failure, wherein they have considered creatinine less than 1.5 as normal and no hepatic encephalopathy. Grade 1 is a single renal failure or single non-kidney organ failure. Okay, grade 2 is 2 organ failures. Grade 3 is 3 or more organ failures. Okay, so there is something called as a acute on chronic liver failure and acute decompensation. So what is the difference between these two? Acute decompensation is always considered in a patient or like in a patient with underlying cirrhosis. Okay, acute on chronic liver failure, it can be a CLD or a cirrhotic patient. And here the time from insult to presentation is considered is within 4 weeks, whereas here in acute decompensation, it is considered up to 12 weeks. Okay, what is the importance is that reversal of recovery is uncommon in these patients with acute decompensation, whereas half of these patients with the acute on chronic liver failure can recover. Okay, so what will be the changes? What is the effect on these organ systems? We looked into, there will be a decrease in the mean arterial pressure. So early goals of therapy should be maintaining the volume status of the patient, maintaining the MAP, giving albumin. So that is important. Coagulopathy, if the patient is coagulopathic with a hypofibrinogenemia, thrombocytopenia, or if there is a factor deficiency, you need to kind of replace if the patient is bleeding. Neuro-wise, hepatic encephalopathy, we looked into the management. Gastrointestinal bleeding can happen. So ulcer prophylaxis, if the patient is coagulopathic, lung risk of aspiration, if the patient is encephalopathic, lung protective ventilation, if the GCS is low or if the PF ratios are low. Kidney-wise, patient can have a hepatorenal syndrome. Okay, so in hepatorenal syndrome, we look in detail about hepatorenal syndrome. Infections because of complement deficiency, immunopheresis, patients are at a risk of Five common infections in CLD patients is what they say. One is community-acquired urosepsis, skin and soft tissue infections, spontaneous bacterial peritonitis, and infective endocarditis. So these are the five most common infections in any patient with chronic liver disease. So there is always a pace of continuous inflammation, destruction, and regeneration, which is happening. So when we look into the etiology, so the precipitating factors is what we initially talked about. That is the acute insult. Acute insult can be alcohol by itself. So alcohol leads to cirrhosis, different stages, steatosis followed by fatty liver, and then hepatitis, and then alcoholic liver disease. Non-alcoholic fatty liver disease is something that is related to hyperlipidemia, obesity, diabetes, and steatohepatitis. Chronic viral infections can be HBV reactivation, which is supposed to be very, very common in the Western population, as well as chronic hepatitis C, D, Epstein-Barr virus, cytomegalovirus, herpes simplex, influenza, leishmaniasis. So these are the other important infections which can result in acute and chronic liver failure. So other causes would be alpha-1 antitrypsin deficiency, hemochromatosis, that is due to high ferritin deposition and hemosiderosis that can result in organ fibrosis. Wilson's, where there is copper accumulation, which will result in liver failure, autoimmune diseases due to autoimmune antibodies, primary biliary cirrhosis. This is due to destruction of the intrahepatic biliary channels and portal inflammation and scarring. Okay, this primarily affects the portal inflammation. Next is primary sclerosing cholangitis, wherein there is a decrease in the size of the intra and extrahepatic bile ducts due to inflammation and fibrosis. Okay, so autoimmune causes we have already seen. We'll have to evaluate for the autoimmune antibodies, anti-LKM antibodies, and smooth muscle antibodies. Also look into hyper gamma globulinemia. Drugs, amiodarone, isoniazid, methotrexate, any alternative medications, phenytoin, nitrofurantoin. So Budd-Chiari is another important, idiopathic being the last cause. So these are the inciting factors or the etiological factors or cause of acute insult to the liver. So looking into the pathophysiology. So what happens is there is cirrhosis, that is fibrosis, resulting in increased portal pressure, portal hypertension. So what happens with portal hypertension? There is mucosal edema in the gut. There can be increased translocation of the bacteria, resulting in increase in the DAMPs and PAMPs. And there is a cascade of inflammation that happens, increase in the free oxygen radicals and nitrates, resulting in splanchnic vasodilatation. So when there is splanchnic vasodilatation, what happens is that there is a low volume status. There is a hyperdynamic circulation which is going on. There can be decreased perfusion to the organs, okay, in the kidneys. There is, because of the free radicals, there can be capillary dilatation in the lungs as well, which results in hepatopulmonary syndrome. Okay, and hepatic encephalopathy because of multiple neurotoxins and ammonia. There can be adrenal dysfunction. So this is the pathophysiology of decompensated cirrhosis. And when we are classifying this clinical course of cirrhosis as compensated and decompensated, there are 5 stages that are being described. Stage 0 is when there is no varices and mild portal hypertension. Mild portal hypertension is defined by the liver, the score, liver stiffness score, that is more than 15. That is more than 15 but less than 20, and the hepatic venous portal gradient, the normal hepatic venous pressure is less than 5. So if it is more than, the gradient is more than 5 to 10, it's kind of normal. If it's more than 10, it's abnormal. So grade 0 is almost normal. And in grade 1, no varices, and the hepatic vein portal venous gradient is more than 10. So this is something that is clinically significant. Grade 1 is clinically significant portal hypertension, but no varices. Grade 2 is when the varices happen and there is clinically significant portal hypertension. So this is a state of compensation. 0, 1, 2 is stage of compensation, whereas decompensated when the patient starts bleeding. Okay, stage 3 is when the patient starts bleeding. First bleeding with the first non-bleeding decompensation, second decompensating lesion. So these are the different stage. Stage 6 is late decompensation, ascites, jaundice, infection, and other issues develop, and the patient finally goes into a state of non-recovery. So these are the various clinical cores of cirrhosis that we have looked into. And complications, the most important when we are talking about ACLF, we'll have to mention the grades, pathophysiology, triggers, and then most important being the complications. 4 most important complications: ascites, hepatic encephalopathy, GI bleed, and HRS. So we looked into encephalopathy. Now we look into ascites, HRS, and later bleed. Other complications that can happen is hyponatremia, hepatic hydrothorax, relative adrenal insufficiency, hepatopulmonary syndrome, and cardiac cirrhosis, cirrhotic cardiomyopathy, and portopulmonary hypertension. So a small word on this hepatopulmonary syndrome and portopulmonary hypertension. Hepatopulmonary syndrome is due to a shunt which is developing in the lungs due to the capillary vasodilatation. Okay, this can be identified by bubble echo study. Okay, the treatment for this, there is no proven treatment for this. Oxygen supplementation to the patient, ultimate would be a liver transplant. Portopulmonary hypertension. The main pathophysiology in portopulmonary hypertension is that there is an increase in the vascular resistance in the lungs. So because of the increase in the vascular resistance, the the pulmonary pressure goes up. So this can be treated with some measures like bosentan, endothelial receptor antagonist. So all those things can be sort of beneficial, but ultimately liver transplant would be the final therapy for this. So next we'll first looking into management. We'll have to mention that the primary etiology of decompensation, that is the precipitating factor, is something that you need to attend to. So correct the etiological factors and some of the factors that affect in pathogenesis of cirrhosis, like for example, patients who develop fibrosis, further going into portal hypertension, non-selective beta blockers have been studied. So carvedilol is something that can be given to patients even prior to decompensation. So this decreases the portal hypertension. So carvedilol started at 6.25 and titrated even up to 12. So based on the patient's tolerance, based on the systolic blood pressure, that can actually be titrated. So this increases the nitric oxide, and carvedilol increases the nitric oxide and it decreases the portal pressures as well. So that's supposed to be beneficial. Long-term prophylaxis, actually some patients will be put on lactulose, rifaximin on a long-term basis as well. So those are kind of factors that can be done even prior to decompensation. So when the patient presents with the ascites, even if so all patients with grade 2 or grade 3, grade 2 is nothing but moderate ascites, grade 3 is tense ascites. So you need to do a diagnostic parasynthesis and look in for the cell count and proteins. So the neutrophil count is very important, and neutrophil count of more than 250 cells denotes SBP, and the protein ratio, you'll have to calculate the SAG. A high SAG denotes nothing but cirrhosis. It denotes there is an increased risk of translocation of bacteria from the gut into the blood. So a high SAG means there is an increased risk of translocation. Okay. And moderate restriction of fluids should be done, and salt restriction is also recommended in patients with ascites. In case of refractory ascites, how do we treat refractory ascites causing some problem to the patient, like breathing difficulty, or if the patient can become because of there can be IVC compression. So tense ascites, large volume paracentesis, always replace the volume with albumin. Okay, 8 grams per liter of the ascitic fluid removed. So that is something that can be done. So diuretics also remain a mainstay of treatment. So what is diuretic resistance and diuretic intractable? So diuretic resistance is, even though you're giving diuretics, the patient develops ascites or it does not come down. So that is diuretic resistant. Diuretic intractable means the patient does not tolerate the diuretic because of complications of the diuretics as such. So the patient can be either resistant or intractable to diuretics. So that is one of the cause for refractory ascites. Other then always, if there is a refractory ascites, do a large volume paracentesis, replacing it by albumin. Ultimate treatment would be TIPS and then liver transplant. So how do you approach? So we looked into treating the precipitating factors, preventing decompensation, some of the medications that can prevent decompensation, and if the patient has gone into a stage of ACLF with extrahepatic manifestation, we looked into what are the extrahepatic manifestations that can happen. So how will you kind of treat it? So brain encephalopathy, lactulose, rifaximin, CRRT, extracorporeal albumin dialysis in case of refractory encephalopathy. So this is related to the brain. Pulmonary, you have to screen for infections because the chances of infections are very high in these patients. Hepatopulmonary syndrome and portopulmonary hypertension that we already saw. Coagulopathy, if the patient has has a low coagulation factors or if the patient is in coagulopathy, then if there is any invasive procedure, then you have to transfuse, or if the patient has bleeding manifestations, then transfuse. And if the patient does not have any coagulation abnormality, consider DVT prophylaxis. Okay, circulation. Ideally, we need to manage with adequate volume replacement in these patients because there is splanchnic vasodilatation, and but there is a tendency for these patients to develop hyponatremia as well. So you need to kind of personalize the goals of fluid management in these patients. Acute kidney injury, HRS, we'll be looking at this. CRRT, albumin terlipressin, and then refractory, going for CRRT. RRT. Then liver specific, there's no definitive treatment in terms of liver, only in case if you're planning for a transplant, artificial or bio-artificial extracorporeal liver support, plasma exchange, there are ongoing therapies. Okay. So how will you stratify these patients having acute on chronic liver failure? So in ALF, we looked into the King's college criteria for prognostication, and you defined your patients who need a transplant or who need a transplant. So in this, you look into the ACLF grade. Okay, MELD has been initially been used. The MELD more than 30 subgroup improved survival. Now we are looking more in terms of the ACLF grades. Okay, ACLF grade 2 and 3. So if the grade is high, like if the grade is 3 and there is a contraindication to liver transplant, what are the contraindication to liver transplant? If the grade is very, very high, so they look into the Cliff C ACLF score that is more than 64 or 70 at 3 to 5 days. So the patient has come into you, you have initiated treatment, and you're looking into the score at 3 to 7 days. Between these days, you look into the score. If the score is very high, more than 60 or 64 or 70, and there are more than four organ involvement, then it is one of the contraindication for liver transplant. Other contraindication, poor neurological status, for example, brain dead or vegetative state, that is one. Age more than 60, any other malignancy in the patient. So these are other contraindications. So if the patient has those contraindications, discuss about palliative care to the patient's family. Okay. So that is on ACLF grade 3 with contraindication. So some patients with a low grade 0 to 1 who can improve with the supportive care and appropriate reduction in the triggers or treatment of the precipitating cause. So they can improve. So this is low grade. Patients with persistent ACLF grade 2 to 3 in the absence of contraindication to liver transplant. So in these patients, you will have to categorize them. If they are considerably suitable for transplant, go ahead with a transplant especially within the window. So proceed with the urgent liver transplant. And in scenario when the patient is very sick, postpone liver transplant, reassess and discuss regarding palliative care. So regarding some of the studies related to liver transplant, the canonic study. So in patients with ACLF, grade 3, early liver transplant improved survival, mostly 20% of the patients. So this is one important study. So regarding other liver support system, Mars and Prometheus. So Helios and Relief is some recent study which showed there is no benefit of these liver support systems. And there is an ongoing trial on plasma exchange as well. This is the Apache trial. So these are the important trials related to the extracorporeal supports in and liver transplant in patients on ACLF. So that will be the ultimate management of patients with ACLF. So other complications. So spontaneous bacterial peritonitis. So how can you define spontaneous bacterial peritonitis? It's bacterial infection of the ascitic fluid without any intra-abdominal surgically treatable source of infection. That is, there is no bowel perforation. Okay, there's no other surgically treatable cause like a abscess or any other thing. It's a without any kind of pathology, just because of the bacterial translocation from the gut to the blood, to the peritoneal fluid, the patient has developed the bacterial peritonitis. The incidence being 3.5% in outpatients and 10% in hospitalized patients. The mortality exceeds 90%. Okay, and with appropriate treatment, it can be reduced to up to 20%. So what will be the clinical features? The classical triad will be fever, abdominal pain, increasing ascites. Okay. So other local symptoms would be peritonitis, vomiting, diarrhea, ileus, and systemic features, fever, chills, altermentation, then white cell counts, tachycardia, tachypnea. So those are other symptoms. Complications, worsening of liver function, hepatic encephalopathy, renal failure, GI bleed, and shock. So how will you diagnose? Perform a diagnostic paracentesis, send it for cultures, and also send for blood cultures. So when you look into the diagnosis, you look into the cell count and the protein. So if the neutrophil count in the ascitic fluid is more than 250 per cubic millimeter, so it is diagnostic of spontaneous bacterial peritonitis. If the neutrophil count is less than 250, but the gram stain is showing a positive bacteria or the culture is showing a positivity with signs of systemic infection and inflammation, you treat it as bactericidis. Okay, the cell count is less, but still there is bacterial infection in so in that scenario also you go ahead and treat with antibiotics. A serum ascitic fluid albumin gradient is consistent with portal hypertension. A more than 1.4 denotes increased risk of infection. Okay, a protein less than 1 also denotes increased risk of spontaneous bacterial peritonitis. So how does this happen? So due to increased systemic portosystemic hypertension, there is mucosal edema of the bowel wall. So because of the bowel wall edema, it increases transmural migration of the enteric organisms into the ascitic fluid. Also, because the liver function is impaired, there is in fact phagocytic function. Okay, and impaired immunological activity as well. Okay, the complement levels will be low. There is immunopheresis. The phagocytic action will be low. So this is the important cause of spontaneous bacterial peritonitis. So secondary bacterial, when should you suspect secondary bacterial peritonitis? For example, you have done a ascitic tapping sent and the cell counts are more than 10,000. Okay, so that is something very, very high, a very high ascitic neutrophil count, and your gram stain shows multiple organisms. Okay, or a culture report which shows polymicrobial growth. Okay, that denotes there is some perforation in the gut. So definitely that indicates a secondary bacterial peritonitis and a high ascitic protein concentration. So these are the findings. LDH will be high, low glucose concentration, elevated protein. So these are the findings in secondary bacterial peritonitis. If you are suspecting a secondary bacterial peritonitis, immediately shift the patient for a CT scan and consider early surgery if you diagnosed a bowel perforation. Okay. So we have looked into this. Any patient presenting with ascites, do a diagnostic tapping. Diagnostic tapping, looking for looking for the neutrophil count. If the neutrophil count is normal, if the neutrophil count is more than 250, you start the patient on empiric antibiotic. So what will be the antibiotic that you will consider? Normally, third generation cephalosporins have been recommended. But due to if the prevalence of MDR bacteria is very high, think of piperacillin tazobactam. If there is a high prevalence of ESBL, or if your culture turns out to be positive for ESBL, then think of carbapenem. So for gram-positive cover, glycopeptides, daptomycin, and linezolid should also can also be added. Okay, so most commonly it will be E. coli or enterococcus. Always think of E. coli and enterococcus in patients with spontaneous bacterial peritonitis. So if the patient you had started antibiotics, also along with the antibiotics, consider albumin, because these patients are at high risk of acute kidney injury or HRS. So you need to consider expanding the plasma volume by supplementing with albumin. Albumin should be given at 1 gram per kg per day, then up to 3 days. Okay. So, and after your final culture reports, you narrow down your spectrum. So if the cells are negative, if the cells are less than 250, then do you treat with antibiotic? No. If the patient has some signs and symptoms, the patient has tenderness in the abdomen, vomiting, and features of sepsis, I mean, features suggestive of some infection, then you start on empiric antibiotic therapy and look in for the final culture report. Sometimes the cell count can be low, but the culture can turn out to be positive. In that scenario, it is known as bacteriocytis, and you treat the patient and then repeat a diagnostic paracentesis when the patient has kind of recovered. Most of the patients, so why do you give albumin? To prevent acute kidney injury. Why? The incidence of acute kidney injury is 40% in the patients who have SBP. So we had a look at the spontaneous bacterial peritonitis. The next important topic or complication of acute and chronic liver failure is hepatorenal syndrome. So what is hepatorenal syndrome? So it's a serious complication of end-stage cirrhosis and portal hypertension, which is characterized by increased planktonic blood flow, a state of decreased central volume and decreased GFR. So we look at the pathophysiology or hallmark of HRS. So why does this happen? So in advanced cirrhosis, there is portal hypertension. Because of portal hypertension, there is vasodilators that are being released. That is nitric oxide, prostaglandins, endocannabinoids. So all these are being released. This results in splanchnic arterial vasodilatation. So this decreases the SVR. So there is a hyperdynamic circulation which happens, and the effective arteriolar volume comes down. There is hypovolemia. Because of hypovolemia, what happens is that there is activation of the other systems like renin, angiotensin, aldosterone system, and sympathetic nervous system, and arginine AVP also. Okay, so all these things get activated, and this acts on the kidney. So the main action of all these things would result in renal vasoconstriction. Okay, if it results in renal vasoconstriction, ultimately the renal perfusion goes low and the GFR also goes low. So this results in acute kidney injury. Also, along with this, there can be other systems which can be contributory. Because of cirrhotic cardiomyopathy, the cardiac output can come down, which will also result in effective arteriolar hypovolemia. There is increased bacterial translocation, increase in the PAMs and DAMs, which will also stimulate an inflammatory response. And there can be endotoxins, cytokines, and tumor necrosis factors, so interleukins, everything causing a high inflammatory state leading to vasodilatation. So all these factors will ultimately contribute to renal vasoconstriction and decreased GFR. So this is the pathophysiology of HRS. So traditional classification, if we look into old classification, it has been classified into HRS type 1, 2, 3, and 4. So this is based on the time course and precipitating factors. So type 1 is rapidly progressive acute renal failure. Type 2 is subacute. Type 3 is 1 or 2 superimposed on CKD. Okay, type 4 is fulminant liver failure. So the current classification, what we follow is HRS AKI and HRS NAKI. So in this factor ultimately denotes that, so you have cirrhosis with ascites, and you rule out all other factors that can cause acute kidney injury, and you have the definition of acute kidney injury. So this is HRS AKI. So you have cirrhosis with ascites, and you have the definition or the criteria fitting into acute kidney injury. That is increase in creatinine more than 0.3 milligrams per deciliter in 48 hours, or more than 50% increase in the last 3 months. So this followed by you rule out other causes. So after no response, after volume expansion, withholding diuretics, and volume expansion with albumin, that is 1 gram per kg per day for 48 hours, and then withholding diuretics as well, absence of shock, no current or recent use of nephrotoxic agents like NSAIDs, and absence of parenchymal kidney disease, like there's no proteinuria, no hematuria, proteinuria defined by more than 500 milligrams per deciliter, and no hematuria more than 50 RBCs per hyperfil, normal kidney ultrasound. There's no structural abnormality in the kidney also. So you rule out other causes, and we don't have any established cause after you have improved the volume status also. That is HRS AKI. So what is NAKI? So AKD and CKD. So acute kidney disease is when your creatinine increases to less than 50% in the 3 months. This is more than 50%. So this is less than 50%, and still your GFR is less than 60. No other cause of kidney disease similar to this, and cirrhosis, patient has cirrhosis with ascites. HRS CKD is Patient, this is actually mandatory criteria. Cirrhosis with ascites should be there. GFR is less than 60 and no other cause. This is more than 3 months. So this is the criteria for hepatorenal syndrome, and you defined the stages of kidney injury by 1, 2, and 3. 1 more than 0.3 milligram per deciliter increase in the serum creatinine, or 1.5 times increase. Twofold 2 to 3 increase is stage 2, and stage 3 is more than 4 or an increase or initiation of RRT. So based on your criteria, you have to stage it as 1, 2, and 3. So what are the risk factors? Risk factors being, we saw SBP is one of the most important. Other infections also, any infection, okay? So any systemic infections can be one of the reasons. Large volume paracentesis, more than 5 liter without adequate albumin substitution is an important cause. Bleeding from esophageal varices, post tips, any diuretics, NSAIDs, IV contrast can precipitate a acute kidney injury. So main treatment would be avoid nephrotoxic agents, avoid nephrotoxins, diuretics, use 20% albumin during large volume paracentesis. So based on the stage, okay, aka 1, 2, and 3. So 1, usually you discontinue all the nephrotoxic agents, any vasodilators like proton, the patient will be on beta blockers. So stop that as well. NSAIDs, diuretics, all those things you stop, and plasma volume expansion. Then observe the patient. There can be resolution. If there's no resolution, the patient can progress to stage 1B, 2, or 3. So in this situation, you consider albumin 1 gram per kg for 2 days and see if there is resolution. Yes, if there's no resolution, then consider vasoconstrictor therapy like terlipressin. And then if the patient goes into meets the criteria for renal replacement therapy, consider RRT. So the dose of albumin is 1 gram per kg for the first 2 days, and then followed by 20 to 40 grams IV OD after 2 days. So how does albumin helps? It improves the intravascular volume. It also acts as an antioxidant and anti-inflammatory action. It mitigates the inflammatory state. Okay, it also binds to many of the substances like bacterial products, bile acids, cytokines, nitric oxide, endotoxins. So it has a ability to bind and kind of improve the kidney functions. So other thing is terlipressin. So terlipressin is a vasopressin analog which acts on V1A vasopressin 1A receptor. It primarily acts as a splanchnic vasoconstrictor. So the dose is starting from 0.5 to 1 milligram every 4 to 6 hourly. Dose can be increased to 2 milligram every 4th hourly. Non-response to treatment is defined by less than 25% reduction in the creatinine level after 3 days and no side effects occur. Okay, so this is defined as a non-response to terlipressin. So if there is a non-response after 3 days, there's no point in continuing terlipressin. So the side effects of terlipressin, very important side effect being ischemia. Patient can have intestinal ischemia. Digital ischemia is something that we have commonly seen. Peripheral vascular disease, coronary artery disease. You'll have to take an ECGs at least every day or every alternative day in patients who are on terlipressin. Respiratory failure, very common finding would be diarrhea and abdominal pain. Okay, so this is about terlipressin. Next vasoconstrictor that we can consider is norepinephrine. It acts through the alpha-1 adrenergic receptors on the smooth vascular smooth muscles. Dose being 0.5 to 3 milligram per hour. Continuous infusion should be continued. So other drugs which can be used are midodrine, which is also an alpha-adrenergic agonist, and octreotide, which is a somatostatin analog. Midodrine doses are 7.5 milligram up to 12.5 milligram 3 times a day. So maximum can be titrated to achieve an increase in the mean arterial pressure of 15 millimeters of mercury. Octreotide 100 to 200 micrograms subcutaneously every 8 hours. So if the patient does not respond and goes into a progressive renal failure resulting in volume overload, uremia, and electrolyte imbalances, consider RRT. So it is also a bridge to transplant. So CRRT, the mode of RRT, CRRT in patients with who are hemodynamically unstable and who have increased intracranial pressure. So in that scenario, you have to consider continuous renal replacement therapy. Okay, and Mars is something that can also be tried, but there are no quality evidence supporting use of molecular absorbent recirculating systems. So tips could improve kidney function by improving the serum creatinine, sodium, and urine output. And it could actually potentiate precipitate encephalopathy as well as hepatic failure. Okay, there is an ongoing trial, liver hero trial, wherein HRS AKA patient treatment with tips, it compares the efficacy of transplant, safety of TIPS implant and the conventional therapy, terlipressin and albumin. So this is an ongoing trial. So liver transplant remains the definitive treatment for HRS. Okay, in patients with HRS, how will you decide whether the patient needs only liver transplant or simultaneous kidney liver transplant? So this decision has to be made. So this is based on this guidelines, the European guidelines. There are various guidelines which suggest different criteria. If you look into the European guidelines, if the GFR is less than 30 and the patient is on dialysis for more than 8 to 12 weeks, you consider simultaneous liver and kidney transplant. So you wait for 8 to 12 weeks for kidney to recover. So if the kidney recovers in this period, only a liver transplant is done. Based on US guidelines, they suggest waiting for 6 weeks. Okay, more than 6 weeks, if the patient is dialysis dependent, you go on for simultaneous liver kidney. Canadian guidelines suggest a 12 weeks. So the duration is between 6 to 12 weeks based on various guidelines. So response to therapy and all that, you can decide based on the creatinine decrease. That is, we looked into is the creatinine decrease less than 25% from the peak value. Or you can increase the terlipressin stepwise also. Okay, and if the patient goes on renal replacement therapy, then there may not be any benefit of using terlipressin, then you can stop it. So these are the various modalities of management of renal hepatorenal syndrome. So we'll look into another topic now. So this is also an important question, either clinical or in theory. So use of albumin in ICU. So looking at albumin, some basic idea about albumin. So the molecular weight is 66,500 Daltons. So it is responsible for about 80% of the intravascular oncotic pressure. It is important for regulation of colloid osmotic pressure. So various action of albumin, if you look into, it's a nitric acid modulator and buffer. It's a weak acid, so it can increase the albumin gap, anion gap. So when you're calculating your anion gap, you also need to make sure it is corrected for your serum albumin. So 2.5 will be your factor. So that you have to remember. So again, maintaining the microvascular integrity, that is endothelial glycocalyx. It plays a very important role in maintaining the endothelial glycocalyx. So other physiological important functions, when we were talking about albumin in HRS and SBP and all that, we saw that it has some anti-inflammatory properties. It has antioxidant properties. It can bind with various substances, like it can decrease the toxicity of the drugs, but in case it can decrease the efficacy of our drugs also. Whatever potential drugs we are using also, it can decrease. So it binds with various substances like arachidonic acid, metabolites, fatty acids, vitamin D, many of the hormones like thyroid hormone and many of the hormones. Okay, drugs like anti-epileptics, anticoagulants, antibiotics, digoxin, NSAIDs, sedatives. So it binds with many of these drugs as well. It binds with bilirubin, amino acids, cortisol, and many electrolytes, okay, calcium, magnesium, all those electrolytes, and nitric oxide as well. So that is one property of albumin. It has very small anticoagulation property and vasodilatation property as well. Okay, so endogenous binding and transport of many of the many substances as well. So these are the physiological functions of albumin. So what is the evidence of using albumin in ICU? If we look at high quality evidence, the beneficial effect is in cirrhosis with spontaneous bacterial peritonitis. So it prevents hepatorenal syndrome. So that there is high quality evidence for this. Okay, in patients who have hepatorenal syndrome, for treating that, yes, there is evidence. Patient who undergo paracentesis, okay, large volume paracentesis, more than 5 liters, okay, there is evidence for albumin. So these are the three things which has good evidence. Okay, other scenarios where we can use this intradialytic hypotension. For example, if the patient is undergoing dialysis, you want to remove additional fluid, but the hemodynamic status of the patient is not giving you the opportunity, then you can try with albumin. So this is one of some of the low quality evidence. Okay, sepsis with hypotension despite crystalloid resuscitation. So this is based on the Albios trial. Okay, for kind of after you have resuscitated with adequate crystalloids and the patient has not responded. So that is one of the indications wherein it can cause harm. So in traumatic brain injury, definitely not, based on the SAFE study. Okay, definitely you should not be using. Other things, cirrhosis with the extrahepatic infection, there is no role. Okay, and in case of pulmonary edema, fluid overload and all this, it can cause further worsening. So this is the evidence. We look into each and every study in detail. So albumin as a resuscitation fluid. So when we look into the SAFE trial, they compared crystalloid versus albumin. There was no difference in the 28-day mortality when comparing 4% albumin with 0.9% saline for volume resuscitation. But in patients, in a subgroup of patients who had traumatic brain injury, it increases the mortality. So next study is the years study. So there was no difference in saline versus albumin in mortality. So, but still, the Society of Critical Care Medicine, European Society of Intensive Care Medicine, and the Surviving Sepsis Guideline recommend a campaign recommendation of albumin as the choice in patients with septic shock. So this is something that we need to look into. The Albios trial has suggested that so if you have kind of resuscitated the patient adequately with crystalloids, then supplementing with 20% albumin to maintain the serum albumin levels of 3 grams per deciliter or 30 grams per liter. So if you maintain this level, there is a lower cumulative net fluid balance and quicker resolution of shock. So there is some benefit in albumin in maintaining the when we maintain a certain amount of serum levels, so that will result in lesser fluid overload and quicker resolution of shock. This is as per the Albios trial. So is there any benefit of giving albumin for hypoalbuminemia? So normally we all know that for hypoalbuminemia, the half-life of our synthetic albumin is going to be low. So in the long term, it is not going to be beneficial for the patients. So in fact, we need to improve the protein intake of the patients. Okay. So that is where we need to give attention to rather than giving 20% albumin. So where does this evidence come from? This is from the Dubois et al. Trial. So this study said supplementing serum albumin daily in hypoalbuminemic patient. So they did not find any kind of improvement in survival or sustained improvement in organ dysfunction. So this study you need to remember. So deresuscitation. So albumin has a role in deresuscitation. It is used as an adjunct to furosemide in this study, the Martin study. So they found they were able to attain a negative balance and improvement in the oxygenation index. So that is regarding deresuscitation. So other indications we already saw: large volume paracentesis. So if we are doing a more than 5 liters large volume paracentesis, you have to supplement 1 gram per kg per liter of fluid removed. In spontaneous bacterial peritonitis, 1.5 grams per kg, and then followed by 1 gram per kg on day 3. So this is for SBP, for prevention of AKI. And for HRS AKI, 1 gram per kg body weight infused for first 2 days and followed by 20 to 40 gram per kg for the 2 to 16 days. So albumin and renal replacement therapy. So intradialytic hypotension. This is based on the renal study. So this study showed that albumin during hemodialysis improved the hemodynamic stability and improved fluid withdrawal. Okay. Albumin in ARDS, is there any role? Restricted fluid management with reduced fluid intake, use of furosemide, albumin administration to achieve a negative fluid balance has been associated with improved oxygenation, reduced ventilatory requirement, but there's no benefit in outcome. Okay, so there's some kind of benefit in terms of oxygenation and reduced ventilatory requirement, but ultimately there's no mortality difference or major difference in oxygenation. So in cardiac surgery and VA ECMO, priming of the circuit, yes, there is a role for albumin. So this is about the use of albumin in critical care settings. So are there any doubts or anybody wants to kind of share anything? Organ dysfunction will also come in definition. Okay, somebody has asked this question. So in the definition, it is mainly the inciting event resulting in ascites encephalopathy in 4 weeks. Okay, that is the definition. So there's a hepatic insult which is complicated by ascites or encephalopathy. So this is the definition of ACLS, but there are different definitions of the different societies have mentioned, but mainly the Asia Pacific Society is liver centric, wherein they concentrate more on the bilirubin, whereas the other societies have included extrahepatic and intrahepatic causes as well. That is, they have concentrated on the bilirubin as well, and the extrahepatic failure also, they have included it. So when we are classifying this, we already saw that the classification is just not based on the bilirubin. It has included the extrahepatic manifestations as well. So that is what is the major difference in acute on chronic liver failure. See, 5 or 20% albumin, most of the data what we have for HR is SBP, and large volume paracentesis, we normally use 20% albumin. Even in the Albio study, they have kind of used this 20% albumin only. But in fluid resuscitation, sometimes we go ahead with 5%. So normally what we use and the evidence, whatever we look for cirrhosis, SBP and all that, it is, can we get albumin indications chart zoomed in mode? Okay. So are you able to see it? I think if you are looking into your mobile, you can take a screenshot and then you can zoom into. That will help you look into, will give you a better view.